So our next presenter is Anne Wagner. Anne is one of the investigators of the Cognitive Behavioral Conjoint Therapy for PTSD, post-traumatic stress disorder, and MDMA, a Multidisciplinary Association for Psychedelic Studies sponsored trial. She will be leading the mass-funded trial for CBT for PTSD plus MDMA. Anne is the founder of Remedy, a center for mental health innovation, and is an adjunct professor at Ryerson University. Anne has done extensive work with communities impacted by HIV and collaborates on projects with LGBTQ and AIDS service organizations on trauma-informed care and trauma treatment. Anne trains and supervises students in evidence-based PTSD treatment and couples therapy, and provides consultation and training to other providers learning these treatments as well. Anne sits on the board of directors of the Casey House, Toronto's HIV/AIDS hospital, and is the past chair of the Traumatic Stress Session of the Canadian Psychological Association. And so with that, welcome, Anne.
Great, thanks so much for having me. And thanks Elise for that great presentation. Mine is gonna be different. I have no slides. So I decided tonight I'm just going to have a chat with you. So the paper, so I know this is a journal. So I know this is a journal club. And then I asked the organizers, so when we say journal club, do people actually read the paper? Because I know when I'm in journal clubs, I maybe read the title, skim the intro, read the discussion. So I decided instead to maybe give you a snapshot of what the paper that I sent out was going to be about. So to give you some context, I was one of the investigators on a study of cognitive behavioral conjoint therapy for PTSD with MDMA. So what that is, it's a couples treatment for PTSD. And why that's unique is for a few things. So one is that we were actually including both people in the treatment with MDMA. So that means both people took part in the entire therapeutic process together, including both people were in the MDMA sessions. And the reason why we did that is twofold. One, theoretically, we think it's really important that if you're going to do a family or dyadic or couples-based treatment, that both people are actually considered the clients, that their relationship is the client in the treatment, as opposed to just the person with PTSD. Because then it can feel like that person is just sitting with many different therapists, including their loved one. So that's one theoretical reason why we would have both people together. And the other reason is that historically, MDMA was actually first used in couples therapy. And so Sasha Shulgin, who was was the chemist who reinvigorated, let's say, interest in MDMA. He wasn't the original chemist, but he was the one who synthesized it, and therefore it gained much greater, wider appreciation and use afterwards. He and his wife, Anne Shulgin, would do their own experiments with all of the substances that Sasha would synthesize. And with MDMA in particular, they saw a lot of potential benefit for relationships. And so Anne Shulgin is one of the few people in the world I would really give the term lay therapist to. So she doesn't have a degree in psychology or social work, but she is probably one of the most skilled therapists that exist in the world. And so Anne was the first person to ever sit with people in couples therapy with MDMA. And so that was an original use of MDMA and considered one of its potential greatest contributions if we're thinking about a therapeutic or growth perspective of using MDMA in a therapy context. So naturally, then the combination of putting couples therapy, MDMA, and then PTSD, which is actually my research background together, made a lot of sense for us. And when you know about the impact of MDMA, of what it does, so really what it's doing is, when you have PTSD, is that it's quieting down your prefrontal cortex, it's quieting your amygdala, which is the threat center. And so that's the center where in PTSD, we often say the alarm system is on all the time. So the fight, flight, freeze response is constantly going. And so that's your amygdala really, really reacting. And when someone ingests MDMA in that context, the amygdala has a chance to quiet down. And with PTSD, your prefrontal cortex, which is when your ability to have planning, control over and access to your emotions in different ways, that's often very quiet when in PTSD. And so instead, when you take MDMA, it's actually able to come online. So really, if we were to design a molecule to be effective for the treatment of PTSD, MDMA might be it. So if you put that together with also the qualities that it imbues in people of feeling more empathic, feeling like you want to communicate and connect with other people, it makes it a really natural fit to put MDMA in the treatment of PTSD with couples. So we ran this trial. We started putting it together in, 2014. So it was quite a while ago now. And with any clinical research, when it comes to psychedelics, it takes a long time to get it off the ground. So from the first conversations to the developing of the protocol, to getting it all of the approvals, to getting it through ethics, to then recruiting people, it took a number of years before we were finally able to recruit. And so we ran the study between 2016 and end of 2017. So, and we ended up having 6 couples that went through that treatment. And what's interesting is that we actually didn't require it to be romantic couples. And I think that's important because with anything really, we can't necessarily assume that folks are going to be having stable romantic relationships or to be able to engage in a treatment. But what happened was that romantic couples tend to be the folks who are most likely or wanting to engage in therapy together. So it ended up being that we had 6 romantic couples who participated. And we ran the study in South Carolina. So my colleagues, Amy and Michael Mithofer, are the folks who have run the vast majority of the current MDMA trials that have existed. So all the phase 2 trials, they had run all of those studies before. And so we were collaborating with them and ran it out of their clinic in Charleston. And so we had all the setup already ready to go there. And what we found when we ran this treatment was that we used a type of therapy, CBCT, that's a standalone treatment for PTSD. And so what that means is that I would use that every day in my practice with clients who come to see me for therapy for PTSD. And there's good evidence for it. So it's one of the treatments that's been tested in a number of randomized controlled trials in a number of different populations. And so it's one of our treatments that has the best evidence thus far in terms of the treatment of PTSD. So if you think about that on its own, so you're already using something that works for a percentage of people. And then you're trying to add something on top of it. So we're really considering MDMA to be an adjunct to that therapy. It's potentiating or creating, hopefully, an additive effect on top of the treatment that already works for a number of people. So that was the whole concept behind it was, hey, if we add these 2 things together, are we going to find the same results? Are we going to have even better results? We don't know. It's all an empirical question. So what we did was the course of CBCT is usually 15 sessions of therapy on its own. They often occur weekly, sometimes twice a week, depending on how quickly people can want to go through the therapy. And instead what we did is we condensed it down a little bit. So we smushed the timeline. So instead of making it weekly, we did the whole therapy in 8 weeks. And so that means we had certain days where we would do multiple sessions of psychotherapy in one day. And the idea of when you condense dosing like that of treatment is it sometimes can give people a bit of an advantage in terms of, first of all, they're there. So they're going to participate and they're going to engage with the material. You're kind of getting this boot camp, if you will, in terms of getting some of that, especially at the beginning, kind of really getting the wheels in motion. And so we would do that. We did the first 3 sessions of CBCT in one day. And so people would come in and they'd start, and we'd take breaks when they would normally, for example, would go home and do homework or assignments from the therapy. We would just take a break, right? And they would go and have a cup of coffee and do the assignments. And then we'd come back together, and then we'd do the second session, and then we'd have a lunch break, and they come back and do the third. And then that later in that day, we would specifically prep them for the MDMA session itself. And so in that, when we're prepping them for the MDMA session, we're talking about what's that going to feel like? What are some of the agreements that we had ahead of time, including things like that we're all going to stay present for the whole session. So no one's going to leave, even if they feel like they want to, because we can't assure everyone's safety if they're going to leave in the middle of the session. And we review some of the intentions going into the session and what that might look like. And really, people oftentimes are quite anxious before the sessions, because it's not, one thing if, you're taking a psychedelic or an empathogen that you haven't taken before, which is the case for the vast majority of the participants. But also they're doing it with the purpose of going into some really challenging experiences. And so naturally that would bring up a lot of concern, and both for the person with PTSD and for their partner, because a lot of them were, doing this because they wanted the healing for their partner, but were feeling pretty anxious about it. So we would do that prep the night before. And then the next morning, they'd come in and we do a little bit more therapy. And so we get them prepped with a lot of communication skills. And that's really key at the beginning of CBCT, getting people on page with how to talk about things that are hard and how to share difficult information and what to do if you're getting upset and how to communicate that to your partner. So we do that in the morning, and then we'd give the dose of MDMA. And then we'd be there with folks for the full 8 hours of that experience, or however long that was going to be for them. And what I really loved about those sessions, and we learned really early on, was initially we played a little bit with this idea, like, do you do some actual therapy content in those sessions? Like, can you bring in some content of CBCT? And then after the first dyad, we decided, you know what, no, we're not going to. We're going to leave that to the rest of the therapy. And for the MDMA sessions, we're going to let it be and let whatever needs to emerge, be that somatic material. So there's a lot of bodily sensations that come out, and we encourage that. There's a lot of memory that comes through. And what happened for the vast majority of people was that people ended up spontaneously recounting their traumatic experiences, which is fascinating, because normally in therapy, that's not what would happen, right? People are not going to just spontaneously want to start talking about what happened to them. So that would happen. And then there would also be times when the partners would want to be communicating with each other. And so there was always two of us in the room, two therapists, and we would end up learning how to kind of conduct that back and forth a little bit. For example, because we'd want the partner to also be having as in-depth an experience as they possibly could. So for example, when one partner was ready to talk, it didn't necessarily mean that the other partner was ready to talk. And so we would, jot down, for example, anything that they wanted noted, then we'd bring it up another time. Because that can often happen in these sessions, as so much content is coming up. People might feel compelled that they have to share it all, but we really encourage that you're never going to be able to hold on to everything that comes up in this, and that's okay. You don't need to. It's more about the bigger picture, the bigger sensation you're getting, the bigger experience. So we will jot down, if there's a key conversation they want to have or a key insight. And then we would, when the other partner is ready to, as we say, come out, so they'd either be inside, which we refer to as with eye shades on, headphones on, listening to music, and they'd be side by side in these recliner chairs. So they had the ability to either sit or lie or swivel and be able to, face each other or face out. And, if they'd be inside with the eye shades on, headphones on, then they wouldn't be talking with each other or us, but then they would come out and lift off their eye shades and then have a conversation. So we would go through periods of being inside and outside and with both partners at different times. And so that first MDMA session would take place. And then the next morning we'd come together and have an integration session, which was just touching base on what had happened and how they were doing and seeing if there are any side effects or any concerns. And then we would go into several weeks then of CBCT. And so we would use the therapy model of CBCT as the framework to integrate the experience that had happened. And we found that was really helpful and useful for the couples because they had a shared language around what they were experiencing, and they had some framework to tether to. And so when I think about the idea of using a therapeutic framework in in a psychedelic experience, because a lot of people will think, well, isn't that too restrictive, or are they not able to go where they need to go? Especially in the context of couples work, what I find happens is actually the couples can go really deep and have really challenging and intense conversations because they have a framework that they can come back to. I envision it kind of like having a life raft there. And so it's like, if you know it's there, you can actually dive down deeper than if you were floating alone in the ocean without a raft being there. And so I often see that as being the benefit of having kind of this therapy structure around it. So they would do several more sessions of CBCT, and then they would do a second MDMA session, and then we'd finish off with the end of CBCT. So what we found at the end of the study was that for 5 of the 6 people with PTSD, they no longer had PTSD. I believe it was all couples had an increase in relationship satisfaction by the end, which also was interesting because it continued over time. So we followed them up to 6-month follow-up, and it would continue from there. And for that one couple, or the one person who had PTSD where they didn't lose their diagnosis, quote unquote, I'm always a bit of a skeptic if we're only putting our eggs in the basket of diagnosis as kind of the benefit of something, because that person definitely saw shifts. That person continued to see change afterwards. And, while they still had PTSD, it was definitely shifting and changing. So on the basis of those findings, it's a very small sample. And as a scientist, I know I don't want to make large claims off of something that's a very small sample of people, but that got us excited for the possibility of what this could lead to, excited for the possibility of investigating this with a larger group. And so that's what we're gearing up for now. So we have, working on the protocol to do a larger randomized controlled trial of the couples therapy to be able to show what it's like compared to a comparison condition of not having the MDMA. And so we'll be really curious to see what that looks like. From the study we did, if you compare it to other studies, the effect sizes that we were seeing at the end of the treatment, we were seeing higher effect sizes than with CBCT alone, which is kind of fit with our hypothesis, but we, of course, need to then confirm that with larger samples. So I think I might pause there and see if there are some questions.
Yeah, we definitely have some questions rolling in.
Okay.
Well, thanks, Anne. That was a great presentation. So we'll get started with the questions. So from Kevin, we'll start. He was talking about a beta blocker, Propranol, and he's saying it blocks beta adrenergic receptors in the amygdala, which then quiets the activity of the amygdala. And he was wondering if this would be useful as an adjunct with MDMA and or for long-term maintenance after MDMA treatment sessions are over.
Right. So from my understanding, the research on propranolol is actually mostly indicated very soon after a trauma has occurred. So in fact, it's actually the window of when you'd actually be considering it to be an acute stress disorder or right away after trauma. And so what propranolol is doing, it's really aiming to work on the idea of memory reconsolidation and preventing some of these memories that we're working with in our psychotherapeutic trauma modalities from taking shape, really. And so propranolol is trying to block that traumatic memory from forming in a traumatic type of way. And so my suspicion is that it's best used in that window early on, versus what we're doing with MDMA is, in fact, we're doing the opposite, is we're trying to really encourage of going into the memory, looking at it in its full detail, seeing the context that's there, because it's already embedded itself as something that is traumatic and is causing challenge around the meaning making surrounding it. So it's interesting. It's kind of working on several different mechanisms there.
Okay. This wasn't a question per se, but there was some discussion about it in the chat. They were just talking about some concerns about using MDMA in the elderly population. I guess I was just wondering if you've seen any trials where MDMA has been used in older adults. Is it safe or is it not safe?
Yeah, so great question. So the trials that we've run thus far, the upper age limit, interestingly, we didn't have an upper age limit in our study, but the oldest participants would have been in their late 60s. And so and I believe generally the upper limits tend to be when you hit, or for most clinical trials before it kind of feels like it's entering into a geriatric age category or an older adult age category is usually around 75 or 80 tends to be the upper limits. And that's simply because there haven't been the same toxicology studies that have been done with older adults. And so at this point, it's interesting because for example, my next study doesn't have an upper limit, but there would be, if there's any concern around cognition in terms of reduction in, processing or understanding, then that would be a rule out because we would want to be very careful around making sure we're not doing any harm. But yeah, I think the question really is around that we don't actually have data yet. So I think that's more the issue.
Okay. We got a question from Kate. She's asking, are there any must-have skills for a CBCT plus MDMA therapist? And then second question, how do you personalize the experience to suit each individual couple?
Okay. Two big questions. All right. So first of all, so for the, so the skills you would need to be a therapist in this modality. So first of all, the key thing is to be a good therapist. And so I think that's the main thing. We often think about, trip sitting for psychedelics, for example, as being a particular skill set, and then hoping that will parlay into some of these interventions that we're talking about when we're using it as a medicine. And in fact, I really want to emphasize actually the opposite, is that if we're using it, for example, as a treatment for something, we first want the person to be a really, really competent therapist. And so that could be from many different angles. It could be someone who has a master's in counseling. It could be a social worker. It could be a psychologist. It could be, it really doesn't matter what angle you're coming at. It matters the strong therapeutic skills. So that's number one. And then you would need to learn the modality of CBCT. So being able to work with couples and using that particular framework. And then the third piece is, how do you work with a psychedelic? In this case, how do you work with MDMA? And that's a piece that it's interesting because it takes, it is a skill set, but it's more of an openness to understanding the experience of what happens in a non-ordinary state of consciousness. So it's almost an attitudinal stance of working, I think, with MDMA or any other psychedelic as a therapist who is already trained in that regard. So that's what skill set you need. And then, sorry, can you repeat the second question, Eden?
Yeah, she was wondering, how do you personalize the experience to each couple, to suit each couple?
Right. Yeah, that's a great question. And I think the question of personalization comes up a lot, especially when people are seeing the concept of a protocol and going like, well, wait, how does that fit for everybody if it's a protocol? So what I want to really emphasize is that the protocol is this idea of an order or a sequence of things that would be useful to address, right? So for example, it's providing some skills in terms of communication. It's providing some skills in terms of anger management and conflict. It's providing some tools around approaching things that people would normally avoid. And it's really emphasizing, okay, how do you make sense of what's happened and asking those questions? So then all of the content that comes in, so everything you're actually working on, everything that they're approaching, every piece of meaning making they're doing, everything that's stuck is theirs. So in fact, it's inherently individualized the whole time, because the only things you're working on are the things that the couple is bringing in themselves. So you're just, what the protocol is, did you ask the question to make sure that you're getting at whatever the thing is that they need to bring in. So in that way, as someone who walks these worlds between, these protocoled interventions and the psychedelic world, it actually feels like a really natural fit to me to put these things together, to be able to provide a fulsome treatment for folks in terms of working with whatever comes up, both in the CBCT alone, but also in the MDMA session, and then having some of these techniques that come from the protocol to work with it.
Okay. We got another question here from Alex. So do you think MDMA-assisted psychotherapy, CBT or other, could be used in groups? And the group here, I believe, is more than 2 people, so more than a couple. And the example that was given was, say, a squad of veterans, for example.
Mm-hmm. Yeah, I mean, I certainly do. I think pragmatically, we've been thinking through that in our different research teams about like, how do you do it? I think it could be used. And I think, and I do actually think in the future, that's the way it's going to go, because it's way more people will be able to access the treatment if they're able to do it in a group format. And in fact, there's actually a study that's going to be taking place at the Bronx VA with veterans that is going to be a group intervention with MDMA. So some of the questions end up being, do you do the actual MDMA sessions in a group or not, right? So you can think about like the prep and the integration can for sure be in a group context, but then does the MDMA session itself, is that individual or in a group? And I think both of those things can be investigated. And I do think it's totally feasible. I think a lot, like with any good group work, a lot of it would be the setup, the container, the agreements about what you're going to do within that group. And I imagine when you're having a group that's quite big, there'd be much less conversation. So it wouldn't really be capitalizing on that component between people, but rather a further encouraging of people going inwards.
Mm-hmm. So we have another question from Ron here. Any knowledge or evidence that MDMA and psilocybin may combine well in the same session? And within that question, there was reference to some underground facilitators combining MDMA and psilocybin. And then I also believe there's a phase 1 clinical trial going on right now combining MDMA and LSD. So
yeah, the combination I hear more of is MDMA and LSD. I think even Sasha Shulgin had talked about those two working together, especially like with, there's different timings of when things would be used in terms of the desired effect. To be honest, I haven't heard very much about psilocybin and MDMA in the same, taken either simultaneously or kind of stacked on each other in a particular session. I think the experiences of those two medicines may, I think both, for example, I think both could be useful for PTSD, for example. But I think likely their benefits may be separate from each other. And that the experience you might be wanting to tap into would best be served by having these two things be experienced on their own, as opposed to combining them in a session, because I think there's a lot of depth that can happen from both, but in different ways.
Okay. I've got a question here from Giuliano. So is there any reported downers or periods of depression following the therapeutic sessions and doses? And then would people start being depressed like later in the sessions or just after the session is over?
Yeah, great question. So yeah, we would often see as people were coming to the end of their MDMA sessions that they would start to feel, they'd be feeling the loss of the ease that they were experiencing earlier. And so there would kind of be this effect. It always felt, the sun was going down, but it often felt like the sun was going down at those points. And so we'd just be working with that therapeutically. And I think that's the really interesting thing is when you're working with MDMA or any other substance, but MDMA in particular, therapeutically, is that everything is grist for the mill for the therapy and to be worked with. And so it's like, okay, if you're starting to feel lower, okay, what are we going to do with that? How does that feel in terms of how you felt previously and what's happened with that before? And so we just support them through that and normalize that if it's happening in session. That didn't always happen, but sometimes it did. And then afterwards, interestingly, we didn't see that same dip that people often report when they're using MDMA outside of that context. And we suspect it's for a number of different reasons. One is that they're engaged in therapy, right? So they're talking to us on a regular basis. They're coming back around, and they're working through difficult and potentially, traumatic things that have been unearthed. So they're busy doing that. And so it's less about their mood dip. And sometimes people might experience it, but they're engaged in the therapeutic process through it. The other thing is, obviously, the MDMA that they're using in these trials is completely pure and it's not cut with anything. So there's less likelihood that there's going to be other interaction effects that can sometimes be a contributor to people feeling down afterwards.
Okay. So I think we're just going to take one more question because it's just getting past 9 p.m. This one is from Matt, and he was wondering, specific to the trial that you spoke about, what treatments had the participants previously participated in before your trial?
Oh, you name it. They had tried many things. So everyone had been in some type of treatment, mostly many treatments. Everyone had been on various medicines and, losing the term, but they'd been on various drugs. So most of them had been on SSRI of some nature at some point. So people had really tried a lot, and many of them had actually tried things that we would consider even similar to CBCT, like not a couples treatment for PTSD. No one had done that before, but some of them had tried a CBT, some of them had tried EMDR. They'd tried various treatments that would, be kind of best standard of care. So this was a very therapy experienced population that we were treating. And to note, so to be in the trial, folks had to agree to not be on any psychotropic medications. That's the word, psychotropic. They had to agree not to be on them. So that meant that either they were not on them and when they enrolled, or they titrated off of them with supervision from their physician. So that was also important, that we're not mixing psychotropic medications and MDMA.
Perfect, thank you. I'm sure we have a lot more questions. Sorry for those whose questions we didn't get to, but we have to cut it off at some point. And I just want to say thanks again, Anne, for taking the time to give us a very wonderful and intimate presentation and to spend the time answering all of the questions from the audience. So thanks again.